Well, hello, everybody. Welcome. My name is Garrett Schmidt, and I am the managing editor for VBC Exhibit Hall. And I'd like to welcome you all to today's live panel discussion hosted by CareJourney. And it is titled 5 Steps to Success in Risk-Based Contracts. I'm really excited about this topic. We have a lot of people in attendance today, so definitely a hot topic. And so really excited to hear from our presenters today, which I'll introduce in a moment. A few items of note before we get started. Everyone's joined today in listen-only mode, so it's not like a Zoom where we can see you and hear you. It's a traditional webinar format, so you don't need to worry about muting your microphone or anything. Secondly, we are recording the session today, so what's going to happen is after we're done, I'm going to send out everybody that's registered an email, and that email will have a link to the recording. Also, the slides. We have a few slides today, not a ton, but we have a few slides today. And then also it'll be a link to where you can learn more and visit their exhibit booth, which I'll tell you about. And then finally, we want to hear from you today. We're going to have a time of Q&A toward the end. So at any time during the presentation, please submit your question using your attendee module. There's actually a place for questions. It's different than the chat. So you want to make sure you add your questions there. And we'll get to as many of those as we possibly can during the allotted time. If we don't get to your question, we'll make sure to answer it via email afterwards. And again, we do have a lot of people in attendance today, so that might happen. But just again, know that even at the last minute, if you put it in, someone will get to you. So please don't hesitate to ask your question. Finally, without further ado, I would like to briefly introduce our presenters today. We have, first of all, Miss Alyssa Moore, who is a system director. Oh, actually, we're going a little out of order here. There's our moderator. We'll talk about her in a moment. Miss Alyssa Moore, who's a system director, value-based care operations with Baylor Scott and White. There she is. And Miss Ashley King, who is the senior director of network operations and population health with Genesis Physicians Group, ACO. Very excited to have them. And our moderator today is Dr. Catherine Schneider, and she's former CEO of DVACO and former chair of NACOS, and is current CareJourney advisor. Easy for me to say, right? But very excited to have you ladies with us today. So I'm going to turn it over at this time to Dr. Schneider to get us started. So welcome.
Thank you, Garrett, and thanks to all the audience that have joined. Good afternoon to the East Coast. Good morning to the West Coast. I'm coming to you actually live from CareJourney headquarters in the middle of a company-wide hackathon. So I'm in my little glass dock in the box, and there may be some background noise, which I hope you'll pardon me for, but we're having a lot of fun here, and I get to be a judge right after this. So I am thrilled to be here today with our panelists. I love talking about ACO strategies, and I think it's so helpful to hear about what's really happening on the front line, very real practical information in addition to, sort of the loftier theoretical stuff. Go ahead, Deepika, next slide. So just a word about our sponsor. CareJourney is a data analytics platform that is whose mission is to really help provide the insights from patient care information to deliver value and help create a sustainable health system for the United States. We serve many different kinds of customers, mostly with a flavor around value-based care, 60 plus leading hospitals and health systems. We have payers, and we have a whole variety of other kind of innovators that use the tool to gain insights, everything from life sciences to consulting firms to partnerships with other kinds of insights and data tools. Next. We support value-based care using both your data as the customer, for example, MSSP claims data, in addition to very large databases that we tap into for well over 100 million lives, the entire Medicare fee-for-service data set, Medicaid, Medicare Advantage, and some commercial claims data as well. We are providing market intelligence for almost half of the DCE, direct contracting, CMMI, or REACH model now. We help guide network development strategies, which really can dramatically grow, but in a very smart way, network. We have performance data on over 2 million physicians that is organized using proprietary taxonomy and can benchmark against peers in the community. You know, the use cases, we're not going to talk about the CareJourney product really at all after the next 5 seconds, but we're going to talk about sort of this value-based care key needs and use cases for data. So that includes market and cohort intelligence, network strategy, certainly provider performance is a big one, understanding how patients are moving through different in and out of networks and systems, and understanding how to cohort and better manage high-risk populations. So next slide. So here is, I know everybody joined the webinar because we said 5 steps to success, and really we are going to focus on use of data. Data is necessary but not sufficient. Obviously, we can provide all kinds of cool data, but if there is no sort of program or intervention or team that's actually going to do something with that information, it won't get you really anywhere. So data is an important foundation, and that's really going to be our focus area today. And this is really the 5 categories, more so than steps, of how someone going into value-based care and taking, whether it's 2-sided risk or even 1-sided risk, needs to think about categorizing their information needs in order to build strategy around. So first off, patients, you know, who are the patients that I see? What are the characteristics? Whether they're attributed formally within, you know, today, they might be attributed tomorrow. Which are of my patient populations are have the most opportunity compared to sort of where I would expect them to be. And very importantly, what information do I need about patients that I'm not seeing? So what are characteristics of the patients in the market that are not touching me that I might be able to grow and attract in to my organization? Secondly, same thing with providers. Tell me about where the opportunities are with my own providers. How are they performing relative to the market? How can I improve? What are the impactful and impactable? And I say that, that's like I'm going to get a t-shirt that says impactful and impactable, because if an opportunity is neither of those, or it actually has to be both in order to be worth building a program around. And I know we're going to hear some really concrete examples of that from our panelists today. So what do I need to know about my own providers, and who are the providers that are not part of me now, but that maybe should be? Who are the folks I should be reaching out to grow my network or to engage in some way, or who may be, you know, a high value referral opportunity for me? Third, the care journey, or just journey. How are my patients actually navigating through their care experience? What does that episode of care look like, whether it's a 90-day procedure and all the associated costs, or whether it's a chronic condition where you're really looking at, you know, care over 365 days over multiple years? What are the evidence-based gaps in care, and so forth? And what is the journey that I want them to be on? Related to that is looking at waste or low value care. In other words, where are the opportunities where I can take cost and potentially even harm out of the system and the care model in order to win in a value-based kind of organization? Where is that low value care in the network? Is it associated with specific kind of conditions? What share of it do I have impactability over? And importantly, is there low value care that is touching my patients that I maybe not be able to impact directly because it's happening outside of my network? And that's another whole kind of strategy that you would need to take on. And finally, the 5th category is around contracts and contract performance. So very importantly, how am I doing compared to my contract benchmarks? And we are going to touch on our two panelists are both in the enhanced MSSP, but also have many other value-based contracts, as they will tell you in a moment. What is the relative administrative burden of each of my contracts? And very importantly, if I'm thinking about joining a new value-based contract, what is my simulated performance? What is the opportunity there? Will it be impactful and impactable enough that this is a favorable contract? Or do you have to have your negotiator kind of go back to the negotiating table? So these are the 5 categories that we are going to touch on today. Next. So we are now going to do a poll question, and this is about where in these areas are you most lacking information. I'm going to turn it over to Garrett quickly to walk us through what to do here.
Yeah, so on your screen, you should see a question that you can interact with. And if you want to just kind of put in an answer there, we'll give it about 10 more seconds here. And then when we're done with that, I will bring up the results when it looks like all the answers have come in here. Dr. Schneider, are you guys able to see from your end what I had put up?
No, I see the question, but not the answers.
Got it. Okay. Yeah. We still have some results coming in, so I'll just give it about 5 more seconds. And okay, I think we're about ready to go. So I'm going to go ahead and close out the poll, and I'm going to share the responses. So since I don't think you guys can see it, I'll go ahead and read them out.
We can see it now.
Oh, you can see it. Okay.
Yep. So interestingly, it looks like, fairly even spread across all the areas, but this issue of low value care is the most challenging out of the 5. So that's certainly interesting, and I'm happy to hear that as a family physician myself and someone who's been evangelizing about that particular topic for my entire career. It is where we are. The whole reason that we are trying to be in these models is improve sustainability and quality, and the way to do that is by attacking that area of low value care, but it is difficult. So, and there are tools out there to help, certainly. Next. So I wanted to just mention a brief ad here for a free certificate program that CareJourney offers, and not just to customers, around value-based care. And it's a 1 to 2 day workshop. You have to apply and be accepted into it. And we've had, well over 100 people go through this with rave reviews. I'm actually going to be teaching in it myself in future sessions. And it's a really deep dive focus around those 5 areas on how to use data to foster revenue growth and improve patient outcomes specific to value-based care. And so you're welcome to request a spot. This information will come up again at the end. And again, just the way that we've organized sort of those 5 areas of focus is the way that VBC curriculum is organized as well. So if that sort of makes sense to you and you'd like to learn more, or if you have newer folks on your team that kind of need to do a quick deep dive learning around value-based care, please feel free to get in touch through that link. Again, it's probably a close to $2,000 value. It's free, but people do have to be accepted, and they fill up fast. We have sessions, I think, running every month. Okay, so let's dive in here. You were already introduced to our panelists. I want to just mention a couple more things about them. First of all, we have a couple of coincidences that we did not plan. They are both from the North Texas market, which was really a complete coincidence. However, it's actually interesting because they're from very different kinds of organizations. So it's going to be interesting to hear a little bit of compare and contrast around how, like, an independent physician IPA, which is the Genesis Physician Group that you'll hear a little more about, how they strategized on using data to support a clinical strategy and success in value-based care. And we've got Baylor Scott and White Health, which is obviously health system, integrated health system, but also includes a lot of independent physicians in a very large area. So another coincidence that we have is that both Alyssa and Ashley, in addition to being A names, both got their MHAs from Trinity University, which I was really surprised to see in their bios, but both of their roles have deep experience in specifically in value-based care, both operationally and strategically. And again, in not just the MSSP, and they're both in the enhanced program as well, I believe that's correct, but in many other contracts. So the way we're going to do this, and if you joined late, this is going to be a panel discussion. The recording will be available. The slides, we only have a few, will be available. And questions, we're going to tee up and try to leave plenty of room at the end because we have a lot of attendees today, and they should be entered into not the chat, but the question function on the GoTo app. So our two panelists are going to give you a brief overview of their organizations, and then we are going to start to dive deep into talking about what they're actually doing in those 5 different areas. So let's go on to the next slide. I think we are starting with Ashley. Over to you.
Well, thank you, Dr. Snyder. So our organization, Genesis Physicians Group, it is a 35-year-old independent physician association that's based in Dallas with over 1,500 physicians, both specialists and primary care providers across North Texas. And back in 2017, we established our ACO that consists of over 300 primary care physicians. We are responsible for over 100,000 covered lives. With that represents about 13 different value-based contracts. So we cover all lines of business. We do have that traditional Medicare contract. That is our MSSP Level E. We also have Medicare Advantage contracts, commercial contracts, and then Medicaid. Medicaid actually makes up the vast majority of our covered lives, a little over 50% of them. We do have a robust post-acute care partnerships across the continuum, including skilled nursing facilities, home health agencies, hospice, and even rehab. Over the last couple of years, we have developed a community-based organization, or CBO, partnerships, really knowing that healthcare is local. And so we wanted to partner with a variety of different CBOs to help support our patient population across a variety of different needs: housing, food pantries, financial literacy, daycares, a whole lot of different ones that we've worked with to gather a couple of dozen of those. And then lastly, as a service organization, it is important for us to be able to keep our finger on the pulse of how we are providing services to our customers. And from our perspective, those are, as an IPA, our physicians. And so we do measure the Net Promoter Score, and our score is a little north of 51. For those who are familiar with NPS, that's a pretty solid score. As far as on the next slide, we have our strategy for success. That strategy is really predicated on a few different guiding principles. One is the work that we do must be patient-centric. Secondly, our organization exists to provide headroom for our physicians and our advanced practitioners. And then thirdly, in order to understand success, or to get to success, is having that working understanding that is a marathon, not a sprint. We have a variety of different initiatives that we roll out, and some work and some don't. But it's all about being agile and learning from those areas of opportunity and implementing those into operations moving forward.
Okay, thank you very much. And over to you, Alyssa, to tell us a little bit about Baylor Scott and White.
All right, thank you, Dr. Schneider. Happy to be here. The Baylor Scott and White Quality Alliance is the accountable care organization for Baylor Scott and White Health. Baylor Scott and White Health is the largest not-for-profit healthcare delivery system in the state of Texas. And the QA is just about 10 years old now. And similar to Ashley, we are in that DFW market, but we also stand down to South Austin and throughout the Central Texas regions as well. We've been able to grow our network to over 8,000 primary and specialty physicians and APPs. We have over 800 total facilities that are in our network, including post-acute care facilities and agencies. And through our 20 different value-based contracts, we now serve just about 1 million value-based care lives. And again, similar to Genesis, that ranges all lines of business. So we have commercial, including our own employee plan and other employers in our market, and the government space. So Medicare Advantage, we are in MSSP Enhanced currently, and we are in Medicaid and exchange agreements as well. I did think it important to call out that our employed providers and all of our Baylor Scott and White Health facilities are on Epic today, but we do have over 75 different EMRs that we have to interact with for all of those providers, which obviously makes it challenging, and I know many of you experience those same challenges as well. On the next slide, wanted to just highlight, throughout our 10-year history, we have obviously learned a lot of lessons, and two things I wanted to call out that were top of mind, things that we have been working on lately, are focus within how we organize our teams and patient communication. So first, I wanted to talk about how we focus our teams. As I mentioned, we have 20 different value-based care contracts, which is quite robust. And we have learned that it's important for how we design our own team really impacts how we then are able to care for patients. So something we have done recently is create more scope within our commercial team and our government programs team. And I'm personally really interested in organizational design, but I think it could be helpful for many of you thinking about how you continue to evolve your ACO as a team, to consider this as well. There is so much depth of knowledge within those two respective areas that we have found it valuable to create that depth within teams, and that goes into data analytics, that goes into network and our clinical teams as well. And so each department has that subject matter expertise supporting those two big contract buckets. The second thing I would call out is, as an integrated delivery network, we have touch points from the primary care setting all the way through post-acute care. We don't necessarily own all of those different points of care, but we joint venture or partner with those different facilities. And that is really empowered by our mobile applications. The Baylor Scott and White Health has an app that we now leverage quite robustly from the primary care setting all the way through acute stays and post-discharge, which I will talk a little bit more about later. I will turn it back over to you, Dr. Schneider.
Okay, great. So I think that'll be it for now for the slides. And so we can flip into presenter mode here. So I am going to start the discussion by asking you sort of high level, how are you currently using data to improve care outcomes, reduce costs, improve performance in your many risk-based contracts? What data are you using? And then I'll give you the heads up that the next question is going to be, what data do you wish you had that would be helpful that you don't have currently? Let's start with you, Alyssa. What data do you have? Where does it come from? And how are you using it? Sort of high level, and we'll probably get down into a little bit more detail as we go. And by the
Sure,
way, I got
absolutely.
like the PTSD deja vu on the 75 EMRs because I had plus Epic, if that wasn't just enough to have to deal with. So certainly I can foresee your answer around the clinical data is a challenge to capture that. But go ahead. Sorry to cut you off.
No, absolutely, you're right, it is. And that's why claims data is really fundamental to what we use to drive a lot of our analyses and then programming. So foundation of claims data, but also as much clinical data as we can get our hands on. So we pull from Epic and combine that into our data warehouse that then drives really everything that we do. So we have an in-house analytics team, our analytics and intelligence team within Baylor Scott & White Health. And it's really been homegrown to start. We do have different vendors that we work with, but largely we have created the different tools that we've used thus far. And so first and foremost, with the information that we have, our team has built a risk stratification model, as I'm sure many other ACOs have and leverage within their ACO. And so that leverages the clinical claims, financial, social determinants of health, education status, all of that combined so that we can better know our populations. As I mentioned before, the commercial population looks very different than Medicare, which looks different than Medicaid. And so we're leveraging all of those insights to get to know the population first and foremost, and then drive both care management and our clinical programming. But I'll pause there and let Ashley respond as well.
Yeah, similarly to Alyssa, we do have an in-house analytics team, certainly leveraging the claims data that comes from our payer partners. Clinical data, we have, as an independent physician network, all of our physicians are on their unique instance of their EMR. So that's not something that talks to each other completely yet. We have started the journey of implementing a health information exchange for our Medicaid physicians. And so that's something that we're looking to actually get our Medicare physicians on in the coming months to years as well. But we also use ADT feeds to identify real-time admissions, ED visits, and discharges from the hospital. That's actually what our patient outreach teams, our care management, as well as our community health workers use in being able to with the transitions of care. But we also we use a variety of different just visualization tools such as Power BI as well, just from a dashboarding standpoint, and the data that actually flows back to our physicians in terms of different scorecards and reports that we share with them.
Got it. So claims data, EMR data where you can get it, and that includes sort of under EMR, I'm also including sort of the ADT from like your owned facilities and providers, those kinds of real-time notification type of things. But now let's talk about, what don't you have, or perhaps what do you need to go elsewhere to find? I know some folks purchase SDOH data on their patients, from big national databases, or what other data do you wish you had that would help you down your strategic path, Alyssa?
One of the things that's really top of mind for us right now is referral data. So we have a large network, and one of the things that allows us to be successful is knowing where our patients are accessing care and trying to keep that within our network. And so our network team has actually done a lot of research and better understanding how we can track where patients are going within the broader network. So I would say referral data is very top of mind. Clinical data, of course, we are always trying to access that better. I would also emphasize benchmarking, right? So as kind of a connecting point to the data, benchmark data is key. And we obviously leverage HEDIS, but we're also looking for the right benchmark in order to compare and contrast, and that can be challenging sometimes. I would also say patient satisfaction data is something that we are all interested in, and as we become larger and more complex, it's harder to streamline that information into one usable format. And so how do we do that across primary care settings or specialists or different facility types? So those are some of the key areas that we are looking at right now.
So Alyssa, I just want to clarify, when you say benchmarking, this is a little bit of a pet peeve of mine. You're talking about benchmarking with a small b. In other words, like finding the right peer comparisons for whatever kind of data, like quality performance or financial performance. You're not talking about capital B benchmarking, which is like the target actuarial financial total cost of care under your risk-based contract. Is that correct?
I would say yes. It's sort of both and, right? So we know our contractual targets within the quality space, targets are easier to come by, but when we look at financial data and utilization measures more specifically, what is the right benchmark that we should be looking at that is translatable to different populations?
Right. So it's not helpful in Dallas to be compared to sort of, rural Iowa or whatever.
Exactly. And then within MSSP, right, CMS gives us our historical performance. They give us comparators. We're able to access that information through NACOS and other forums. How do we translate those definitions and benchmarks to Medicare Advantage as an example and create consistency in how we as an ACO look at performance and also share that with our providers?
Yeah, and I think especially when it's one thing to sort of look at all ACO performance and find good comparative information, but it starts to get to be really hard when you're doing that individual provider feedback on performance and how are you doing, and especially with specialists who need so much education and understanding about even what is an ACO and what is a total cost of care model, let alone like how are we measuring them, for sure. So that's a challenging area. Ashley, what kind of information would make it easier for you to succeed?
Yeah, I love the ones that Alyssa brought up. A few other ones that I would add to that, especially being in Dallas-Fort Worth, where Alyssa is as well. It's a quite competitive and dynamic space where there's a lot of different options for physicians to participate within different ACOs. And so one of the things if you put your network or your recruitment hat on, that's always helpful in order to actually build and retain a high performing network, is just understanding which PCPs are potentially out there that you could recruit in. So knowing what network affiliation they have. So if you are someone that's looking to grow your MSSP contract and you want to recruit in new doctors, it's helpful to know who's even out there that's currently not affiliated with an MSSP program or an ACO REACH program, and trying to design your recruitment strategy around that. Another point that I would bring up just from an independent network standpoint is one of the challenges that we have realized when it comes to clinical data in trying to close care gaps is that sometimes when those are completed at a specialist, well, I'm going to use the example of the diabetic eye exam. If that's completed at a specialist, and sometimes that information doesn't always get back to the PCP, where it can be documented in the record and actually close the gap and to get credit for that. So unless a practice has a very strong workflow to do that, or has a very strong specialist aligned strategy, sometimes those are missed opportunities. So being able to glean data from aligned specialists is something that will help from a quality standpoint. Mm-hmm. And then the last that I would bring up in terms of data that I wish that we had, about 60% of our patient population are actually kiddos, those that are 18 years or younger. And so what is helpful for us as we start to think through how do we engage our pediatric population is actually getting data around, is there a concentration of those patients, of those kids that belong to certain schools or certain daycares? Being able to do more of a PCP school-based analysis, and then how do we align some of our community-based organizations and just interventions in general to really meet patients where they are as well. So that's something that certainly piques my interest and my team's interest as well.
That's so cool. You know, we spend so much time sort of in the Medicare space, whether it's MSSP or MA, and to think about the school as like your great CBO partner, right? That can, whether it's a school-based health center or, you know, other kinds of resources and how to connect to that's, I mean, it's almost like the analogy to the employer in a way, right? It's where those kids are all day long, basically. Yeah, that's really cool. I never thought about that quite under, you know, sort of a risk context previously. So you mentioned a couple of things, and specifically, like let's dive a little deeper into network strategy. So you mentioned, gee, it would be nice to have information about other, you know, unaffiliated physicians that are not already tied up in other programs that we could grow our network into. I imagine you might want to know not just that they're unaffiliated, but some more characteristics about the practice, like how they might perform or what kind of benchmark they might, you know, bring into your contract. How do you look at perform? I'm going to ask both of you, like from a network perspective, what data do you use or wish you had, you know, very specific to physicians that are not currently yours?
Yeah, I think it somewhat depends upon the contract that we're trying to opt them into. So CMS does have a public use file that they publish each year. It's usually a couple years lag, but it does provide data for those the providers that do take Medicare around some just general statistics around them. So how many patients do they have? You know, so that's a key piece of data that's helpful. So not just who the PCP is that's potentially available, but historically, what's their count of their patient panel size, whether it's from traditional Medicare or some of the other lines of business, but also just historical performance as it relates to utilization measures such as admissions and avoidable ED visits as well, risk coding, what's been some of their historic RAF scores as well, and then quality. Those are some things that certainly would be interesting. You can get some of that from CMS, but for some newer physicians or for physicians that haven't been heavily in the traditional Medicare space, that's not something that's readily available. So that's something that would certainly be helpful as you look to build a strong network and also identify where do you want to put any efforts your team puts forth around recruiting physicians to build your network, but also being able to see, Dr. Snyder, what impact would they make around your financial performance? So almost like scenario analysis. So you know what your current benchmarks as well as your current performance, your PMPM, PMPYs are. But if you were to add provider X to your network, what does that do to your bottom line? That's some scenario analysis right now we don't currently have. It's something that is certainly on our wish list.
Mm-hmm. Yeah, and I imagine, you know, it's the same analogy of growing your network. If you're trying to stand up a brand new risk-bearing entity or ACO, it's the same idea, right? It's there you have zero information on the physicians in terms of, you know, recent claims data, et cetera. So you really be flying blind without being able to access either those public use files or richer, more recent data for sure. Alyssa, anything else when you think about network information?
Yeah, I agree with Ashley's answer. I think that was really well said. Of course, we have a different perspective than an IPA, right? So we have our large cohort of employed providers, and currently the Quality Alliance is we're essentially closed to new providers at this point, just because we have key areas filled. Now, if there is a gap in a certain specialty, then we would absolutely search to fill that. We're always accepting primary care physicians. But going back in time a little bit, when we first joined MSSP, we started as Track 1 in 2015. No downside risk, of course, and that was a great way for us to start learning about our population and our providers, right? So that was pretty early in the Quality Alliance journey, and the program was really valuable in the sense that we started to ingest claims data, we started to learn about the population, and that took time. And that's what I would underscore too, as you're evaluating providers joining your ACO, is that it's going to take time for them to truly understand managing any population. Medicare is a great example of one through these types of programs, but you can't expect, change overnight. So I think being very clear and upfront with expectations around that. We were talking with some providers that hadn't been an MSSP in the past, and to Ashley's point, we started with actuarial analyses. We looked at the financials to see if it would make sense. We look at outcome data if they are in perhaps a Medicare Advantage program already. That's a similar type of population. But also you really have to look at the processes that they have in place. So are they doing risk adjustment, coding and wellness visits? Do they already have an infrastructure in place that you could leverage? So it's not just about their performance. I think it's also about their appetite, their readiness for risk, and just general perspective about what the future of value-based care looks like.
Yeah, and so kind of along that theme, we could spend a whole day talking about this, but feedback, giving providers feedback on their performance, and actually, so for the ones that are in your contracts, can you give me like a sound bite on the secret sauce or magic weapon, magic wand that you have, not weapon. That was a little bit of a slip. Like, what is your secret to, impactable sort of provider performance feedback? How do you deploy that? And it's data-based, obviously, so that's what we're talking about. In 5 lines or less.
I can go first, Ashley. I really like your slogan of impactful and impactable. With physicians, what we've learned very simply is you've got to be direct with what you need and make that very clear to them and give them the right information in the right format that is going to allow them to be successful. They may not need to understand the full strategy of what we are doing with value-based care. Of course, we would all love for every provider to understand that, but I think boiling it down and having accountability around that over time is really fundamental. So yeah, again, we have looked a lot around this. We have built elaborate reports and tools for providers, but I think as much as you can create simplicity for them, the better off everyone will be.
Yeah, and that I just reminded of one time where it's like, tell me the one thing I need to do. Like, they want to do the right thing, but having just like volumes of reports and tables and charts, it's not like they've got 10 minutes to digest. What's the one thing to do? And I remember sitting with an oncologist who was inadvertently getting a lot of attribution, of very, very sick patients that, whose risk score was not capturing their illness because it was during their cancer care. And it was because those patients were actually had PCPs elsewhere and just weren't seeing the PCPs. And so the very simple thing, the step was, please work this list and make sure your patients are actually seeing their PCP, which would then give them the correct attribution, which may or may not be back to our ACO, but in many cases was not. So that, reducing churn in this sort of specialty attribution, that was just one example. Like, just tell me the one thing you need me to do and I'm happy to do it. Ashley, 5 lines or less, secret sauce.
Yeah. Well, I think I agree. I mean, for our physicians to understand the why behind it. So why are we even bringing reports? I mean, we still do education with physicians who have been in some of our value-based arrangements for the last 4 or 5 years, just around why the value-based care is important. What is it? What's the end goal of what we're doing? So really just kind of getting back to ACO 101 around why is that. And then also peer comparisons. We have seen that to be a very impactful way to share data and try to also get action from what we're sharing.
Do you blind it, or do you blind it, or is it names?
We do blind it to a certain extent, but we do blind it, but do show them where they rank in terms of percentile across really all the different utilization metrics that we use as our KPIs, as well as quality scores. And so that is something that we do share with the physician so they can see, well, you have one of your peers who's in the exact same, across the street from you. This is exactly how they're performing and you are, at this percentile compared to him or her. But we found that to be an impactful way to disseminate data. But also the last point I would make around it is connecting the dots. So not just showing data in and of itself, but also connecting dots to the resources that the ACO brings there to help the physician with their performance. So it doesn't do much of any good to tell a physician that you're low performing in your avoidable ED visits or in this particular measure, but actually going, actually closing the loop on where are those opportunities, and then how can those actually be addressed by our care management team is here to help you with X, Y, and Z, or this is something that our risk adjustment team can do. That's where we found that data becomes more impactful. They're not just numbers, but insights when you're able to connect those dots.
Okay, I can't believe that we are starting to run out of time here. I have like a million questions. I'd love to continue the conversation, but for our audience, if you do have questions, please put them into the question part of your GoTo app. And while you're doing that, I want to just going to switch gears a little bit. As you may know, I recently chaired a digital quality measurement task force for NACOs, and both of you have complex, large ACOs with clinical data sitting in a lot of places, and coming up faster than you think is the requirement that all MSSPs do their quality reporting electronically through the ECQM program. I just get like a temperature taking from each of you on your level of fear and financial resources that you're having to sort of tuck away in order to take that on, and would sort of just jumping over all of that and until we're ready to do it on using newer technology like FHIR, is that appealing? If you're up for speaking to that at all quickly, because I know we've got questions piling up.
Yeah, I can start. So our quality team has been tracking this since the beginning. They've been working with our Epic team to understand how we can aggregate data. Epic is, modifying and continuing to evolve its capabilities. So we're trying to evaluate what they can provide in addition to other support services and tools. There is not an easy answer. We are still going to do the web interface reporting for this next year while we figure out next steps, whether that be a registry, ECQM, or the FHIR approach. I think no matter what, it's going to require a little bit of elbow grease in terms of how we continue to do it. Like I explained at the beginning, we have a significant number of tax IDs and groups that we work with, which complicate this type of reporting because it's all payers and all populations, right? So it is stressful and we are evaluating that there is going to be a financial implication as well.
Yeah, and so I would just emphasize for all of the audience, if you're in the MSSP and you're not paying attention to this, you better start, because it's not that far off, and NACOS is trying to advocate, and we're trying to come up with alternatives, but it's scary. Ashley, anything to add to that?
Yeah, we're continuing right now on the web interface pathway, but we are evaluating a couple different options, either the qualified registry vendor. We've been vetting a few different ones, but also potentially leveraging that HIE that I mentioned earlier that we currently have for our Medicaid doctors, possibly expanding that to our Medicare doctors. That HIE does have a qualified registry component to it. There's a lot of obviously non-trivial costs that are associated with that, what equity on internal side, also on the practices side as well. So we're weighing all those different components out to determine the best path forward. But yes, to Dr. Snyder's point, even though it's still a couple of years away, having that roadmap is something that is very critical for your organizational success in MSSP moving forward.
Yeah, thank you guys for sharing that. All right, I don't want to hog the questions. If there aren't any, I've got a million more that I can just keep going, but how do we have questions?
Oh boy, do we. We have a number that came in. This is and probably too many, honestly, to get to all of them. So, but if you do have a question, please go ahead and submit it. Like I said at the beginning, someone will get back to you with an answer via email. So even up to the last minute, go ahead and submit your question. A couple things in no particular order here. I'll jump into some of these audience questions. The first is, how do you hold payers accountable for providing timely data?
Oh, that's a good question. So one of the things we've actually tried to do just from a contractual standpoint is put some language into those around just SLTs, around what, or SLAs around what they should be including in the timeliness of it. It's something we have monthly meetings with each of our payer partners. And so those are things that we certainly bring to those calls if we do not have accurate or timely data. But it's a journey. There's always that one payer that you wish that you could get that more timely data from, but we hold them accountable through our agreements that we have with them.
Can I just add to that? Do you have any like risk-based contracts that you're not getting claims data, but you get the old like PDFs every couple months? Or do you insist on having claims data?
We have claims data for all of our value-based contracts.
Yep. Thanks.
Yes, agree.
Anything to add to that different, Alyssa?
I agree with Ashley. It may not always be perfect, but we do have to stipulate, what you expect in writing and then escalate if you are not getting what you need.
Yeah, so having a good contract negotiator is critical. Next question.
Okay, next question is, a lot of physicians don't know they're participating in an ACO. How do you educate them and change their behavior?
Well, presumably they've all signed stuff and done compliance training, and it's hard to imagine them completely not knowing. They may not be able to answer more than a yes or no, in my opinion. But what do you guys think?
We do have some physicians that question hits home, because we do have physicians, believe it or not, they sign on the dotted line and sometimes don't even realize what they're signing. And so one of the things, we have a team of provider relations specialists, and their job is actually, once someone signs up for a contract and then they have attribution, we do an onboarding meeting with that physician. And so we just walk them through an orientation of the ACO, who are the different team contacts that they would be working with throughout their time as part of our ACO, and then also what are the different measure requirements, just going through all the nuts and bolts of the ACO contract. So that's something just kind of on the front end of with your provider relations network team to do once somebody joins.
Or when you bring them a check. When you bring them a check, that's always a good one.
Okay. That will make an impact. That makes it a little easier for them to remember you. I would just add that from our perspective, we are leveraging our employed medical group as much as possible. So they are the vehicle for value-based care more than the quality lines is now. And that's something that's evolved over time. It's not 100%, but we're working with the medical groups. So they are carrying messages as well. Oftentimes they prefer to be the ones speaking about population health within the practice, and then segue into what they are doing with different transformation initiatives. And so our network team can then focus on independent providers in the market or specialists, whatnot.
Okay. Good deal. Great. Yeah, next question. We only have time for one more, unfortunately. And if I could get a really quick answer on this, because I know that you could probably go on and on, but this question is, let's see, I lost it here. It is, oh, here we go. What are the key differentiators to succeed in commercial risk versus Medicare and Medicaid?
So I would say for Medicare side, certainly, you think about it off your revenue and your expenses, right? So revenue is the risk adjustment portion of it. So making sure that your risk adjustment coding team is educating physicians on how to document at the highest appropriate level of the severity of illness. So RAP is a huge component of that on the Medicare side. And what I would say from the commercial side, where we've seen a lot of opportunities from a cost management, is site of service. So making sure patients are getting care at the appropriate site. And then in-network versus out-of-network utilization. Those are some two huge cost drivers on the commercial side as opposed to the Medicare side.
I agree. That's exactly what we look at too in the Quality Alliance for commercial. It's mostly about network utilization. And then for Medicare Advantage, both revenue and expense management. Within expense management, we take a hard look as well into post-acute care because we have a great deal of opportunity around our inpatient rehab spend and our SNF length of stay. So we have really drilled into those two specific opportunities and seen quite a difference.
Yeah, and in my experience, I mean, one key difference certainly compared to MSSP, at least, maybe less so on MA, is again, your ability to negotiate the terms. And that may include having some upfront payment in the form of a care management fee or something, being able to negotiate the quality metrics like that actually can drive strategy and also actually fund some infrastructure up front, which is really helpful.
I think that's a really interesting topic as well, just for one final word, because as I mentioned at the beginning, we've really seen a difference in initiatives and even staffing models for commercial versus Medicare. And so I think as ACOs become more mature, talking more about how that should look will become more important.
Mm-hmm.
Great, guys. Unfortunately, we are out of time, but I did want to ask this last quick question because it's a good transition into our closing here is in regards to the certificate program, you mentioned earlier, Dr. Schneider, can non-providers attend this program?
Non-providers, yeah, I mean, anyone can apply, certainly. The target audience is folks who are, operationally in value-based care type of organizations. So they certainly do not need to be clinical. In fact, probably the vast majority of those who've participated are not. They're like analysts and managers and so forth.
Yeah, it sounds like a really exciting program. I would definitely encourage everyone who's interested to apply. And I'll send some information to that regard also when I email you later. I wanted to thank our panelists today. Thank you all. This is a really wonderful discussion. And who knows, maybe we'll be doing another one at some point soon. We have so much to talk about. But as we close out, I wanted to encourage you all to visit the CareJourney exhibit booth, virtual exhibit booth at vbcexhibithall.com. And that's also where you can learn a lot more about them and what they're doing in the value-based care space. vbcexhibithall.com is also a great resource for all things value-based care. And in fact, Alyssa Moore and Ashley King both sit on the advisory board. So really proud to have them with us today on this presentation. So yeah, please visit us there. And then finally, if you would like to reach out to the CareJourney team or learn anything more, please feel free to do so. Their information here is, actually, this is about that, the value-based care webinar. Is there a final thank you slide? There may not be, but if you would like to reach out to them, feel free to do so. You can reach out to me as well. I'm happy to facilitate an introduction. But thank you all so much. Thanks again to our speakers. Thank you all for spending your time with us this afternoon. Hope you have a wonderful rest of your day.
Thank you. Bye, everybody.
Bye-bye now.